evening. My name is Sahana. I've been a therapist here at Breakthrough since 2011. So I'm really excited to be talking about falls and fall prevention today. Not excited because there's a fall, but really because this is one area where we can really help and falls can be prevented. I'm just going to give you a brief overview of what we're going to do today. We'll be talking about what are the risk factors for falls, fall prevention, and then Ruchira is going to talk about balance issues, in particular PPPD, which is one of the most common inner ear issues. And then Ricky further on will talk about vestibular rehabilitation. So feel free to stop me at any point. If I'm swallowing words, that's because I'm nervous. Stop me, but remind me where I stopped. So, all right. So, okay, that's a monkey, which means that we have there. All right. That's the actual definition for a fall, but I really think it's an external cause for an unintentional injury. So, some of the statistics, I think you guys can see the second slide there. About 1 in every 5 falls in the United States leads to a serious injury, such as a brain injury or broken bones. About 2.8 million older people are treated in the emergencies due to falls. That's a pretty significant number. 800,000 patients a year are hospitalized because of head injuries or hip fractures alone. About 300,000 older people are hospitalized for hip fractures alone. And about 95% of the hip fractures are usually caused by falling on your sides. And that's the economic aspect of it. About 31 billion spent on fall prevention and fall medical costs associated with falls per annum. So that's a pretty significant number. So it's amazing that we can actually control a lot of factors and prevent most falls. Like we discussed, some of the most common injuries following a fall are brain injuries and fractures. And 95% of the fractures are hip fractures. Some of them are wrist fractures, an arm fracture, ankle fracture, etc. So if you've fallen and you've had an injury, but you don't feel it at that time, still make sure you tell someone that you've fallen. You might have had a brain injury or a concussion, which you may not be aware of. So please make sure you tell someone that you've fallen. I'm going to come to this slide in a little bit. So we'll skip ahead and we'll come back to that, and I'll tell you why. These are some of the risk factors. Of course, there are biological factors that you cannot control. Age, ethnicity, and gender. Females, again, are more prone to falls than males. But this statistic changes if you're over 75 years of age. At that point, males become more prone to falls than females. Also, if you're a Caucasian male over 75, you're at the highest risk for fall. Afro-Caribbeans, Hispanics, and South Asians are slightly at a lesser risk. So let's go over the factors that are really under your control now. This is where we all can help, right? So physical inactivity. So keep it moving. That's the key there. So do what you like to do, whether it is swimming, walking, water aerobics, tai chi, anything. Keep it moving. Stay active. The more you walk, the more you do things that you like, your muscles are engaged, there's less atrophy, the less you fall. So keep doing what you like. The second most important factor is how you are and how things are around your house. About 25% of the falls happen at home. About 56% happens just outside of your house. So if you control most of these factors, you're 25% less likely to fall. We don't have to go into the detail of each one of these because I'm giving each one of you a home safety checklist. So it's pretty handy, so you can go home and work on these. However, some of the major issues here are keeping your house clutter-free, securing your carpet edges with double-sided adhesives, removing or throwing away rugs, removing cords and wires from the floor, adequate lighting in the hallways and bathrooms. Install handrails on stairs. Eliminate low chairs. The lower the chair, the harder it is for you to get up, the increased chances of you falling. Avoid floor wax. Buy a grabber. How many of you keep doing this all the time? And it's hard to pick things up, so buy a grabber, or whatever that thing is called, a picker-upper? Yeah? I don't know. You know what I'm talking about. So buy one of those. And just attend to spill liquids, grease, food, so you don't fall. Okay. Bathrooms. About 3% of the falls occur in bathrooms. However, I, for some reason, thought that number would be higher. I was looking at studies, but apparently only 3% of the falls happen in bathrooms. So install grab bars in the bathtubs, showers, and toilets. Use rubber mats in the tub or the shower, and always use a raised toilet seat. Again, there are bathroom rugs here, which you want to throw away. If you really want to keep them, make sure there's a double-sided adhesive with it. Outdoors. 56% of the falls occur just outside of your house. That could be in your patio, that could be in your just in your front yard or backyard. So it's completely preventable if you take care of a few things there. Make sure it's well lighted. You repair the sidewalks, install handrails, trim all the shrubs around the house, so you have better visibility. Vision and fall risk. I'm pretty sure a lot of you feel distorted when you're coming downstairs. See if you're wearing bifocals. It distorts your vision and it makes it harder for you to see downwards. So if you're feeling some issues there, it's probably just your glasses. So make sure you get annual eye exams and get cataracts or whatever you need to do to take care of your vision. Medication use. Studies show that taking more than 4 medications at a time, irrespective of the type, increases your risk for falls. So probably, when we have a lot of Medicare patients here, so we always ask them for a checklist of the medications that they take. Some of them run pages. There are 10, 15 medications. So if you're taking more than even 4 medications, irrespective of the type, that puts you at a risk of falls. So you really have to be careful and understand what the side effects are of all the medications that you're taking. Be it antidepressants, sedatives, blood pressure medications. I know many of you might, some of you are my patients here, you guys have discussed with me, I feel dizzy and I feel off balance as soon as I get up from a sleeping position. That could be something called orthostatic hypotension. A lot of patients who are taking blood pressure medications might have that. So talk to your doctor about all the side effects of these medications. And some simple steps like reviewing the side effects, sticking to one pharmacy, always having a list of the medications that you take, checking for expiration date, and reviewing your medications each year with your primary care physician. Some of the basic steps that you can take to reduce your risk there. The next most important thing I want to talk to you guys about is the fear of fall. The fear of fall, a person who is scared of falling will actually fall. It's paradoxical, but they actually fall. So if your risk, there's actually a scale to measure how fearful you are of falling. So if that number is higher, you're probably at more risk for fall. So what happens if you're really scared of falling? It changes your balance. It changes your mobility. You start making changes in the way you walk. You'll probably start walking with a sway. You'll increase your base of support. Your speed is going to come down. This will further lead to muscle weakness. Again, you'll start limiting your activities because you feel off. Again, you'll fall. That's when this cycle, this is the slide I said I'll come back to. So you're scared of falling, so you'll start limiting the things that you want to do, which will further lead to muscle weakness. Then you fall, then you isolate yourself from all the activities. You're like, oh, I don't want to go there, what if I fall? And then that leads to depression. You want to start taking antidepressants, that again puts you at risk for fall. So it's like a vicious cycle. So going back again, don't stop what you're doing. Keep it moving. Okay, you're going to hear me saying this a ton of times. I'll probably sing by the end of it. So, moving on. Again, we spoke briefly about this social isolation. Let this not lead to falls. It's a factor that you can easily control. Now, join with like-minded people, enjoy activities that you want to do, and again, keep it moving. Muscle weakness. Decline in muscle strength, whether it is just disuse or you have a serious condition going on, will interfere with your balance and again lead to fall. So you're at a 1.8% increased risk of falling if you have muscle weakness. Certain chronic conditions like diabetes, diabetic neuropathies, arthritis, multiple sclerosis, Parkinson's, stroke, all of these lead to global muscle weakness and balance impairments. That's where we come in handy. We can help you guys in a way that no one else can, not your personal trainer. Okay? Because we want to assess what's causing that. Do you have any range of motion deficits, which is causing mobility impairments? Whether you're weak, what muscle groups are you weak in? What's going on with your gait? What changes are you making with your gait? And do you have questions? Okay, what changes are you making with your gait? And is there a balance issue, or is there a vertigo? Is there a vestibular issue that's affecting your balance? So there are a ton of things that we need to take a look at. So if you start to feel like I am weak, don't stop doing your activities. Come to a physical therapist, okay? We use a lot of scales to assess your risk of falling. So when you come to PT clinics, you probably are given a bunch of these, and I know most of you hate filling them out. It's lengthy, it takes time, but it's really, really useful. So please take your time to fill these out. There are a lot of questions in this which we cannot go with you one-on-one. So this gives us an idea as to what's really going on with you, because these cover every single aspect. So when you're given any of these scales, or maybe even other scales, I haven't put all of them here. So please take your time to fill these out, okay? Now, use of assistive devices. Again, faulty use of a walker or cane can lead to falls. How many of you, at some point of time, are holding on to furniture and walking at home, or holding on to the wall and walking at home, right? Yeah? Yeah? So please try to avoid doing that. That causes serious falls. The piece of furniture, the chair, or the table might move, and you might have a fall. Hopefully not, but there's something easily avoidable. Okay. The next most important thing is foot problems and footwear issues. Conditions such as bunions or ingrown toenails or toe deformities, ulcers on the foot, deformed nails might make it more difficult for you guys to find the right kind of footwear. So you end up wearing, shoes that have that don't have a back, like backless slippers or flip-flops, because it's easy to wear and then it's comfortable. But however, they cause a lot of falls. So try to avoid wearing only socks or flip-flops, stockings, backless slippers. Wear good boots with good traction, especially in weathers like this where it's raining. Try not to walk at home just with socks. Okay? Some of the other chronic conditions that might contribute to fall risks are, I've mentioned some of them here. Diabetes. Again, women with diabetes are at 1.6 times more likely to fall than their female counterparts. Okay? Is this a little cracky?
Yeah.
Yeah. Is that better? Okay. Again, arthritis. Arthritis it's an inevitable change that comes with age. You can't control it, but you can always, you can't prevent it, you can always control it from getting worse. So, arthritis, multiple sclerosis, stroke, Parkinson's disease, Alzheimer's, all these mess up with the tone in your muscles. So if you have changes in your tone, it makes your gait difficult, again leads to muscle weakness. Chronic pain, depression, again 2.2% increased risk for falling if you're depressed. Certain other conditions such as incontinence, cardiovascular diseases, COPD, again, puts you at more risk for falls. Alcohol misuse. I was debating, should I talk about this or not? Then I realized I should talk about this. Alcohol misuse increases your fall risk, not only because you're intoxicated, but the combined effect that it reduces your bone density, leading to osteoporosis eventually. So, use your judgment. Okay, some of the other risk factors here, actually the factors, these are, we've already spoken about this, but if there's any change in your medications, or you've just had a recent infection such as pneumonia or something going on like that, or just had the flu, chronic pain, lack of sleep. A lot of you will agree to this. You feel off the next day if you haven't had a good night's sleep. Moving to a new home, depression, reducing your activity level, and if you've just changed your assistive device, say you were using a cane and now you've started using a walker, or a sudden change in your assistive device may also lead you, might also put you at an increased risk. We're going to talk a little bit about controlled fall. This is not really for a person who's falling, but rather for the caregiver. It's not easy to control somebody who's falling. It happens so quickly. There is a recipe here to help that person, but you can't by no means prevent them from falling. So if you see somebody falling, hold on to them, but don't prevent them from falling. It's going to put both of you in danger. Let them fall. Guide them. It's a controlled fall. So you guide them, but just make sure that head is protected. That's the whole point of this slide. I can show it to you with Ruchira, but I think you all get the point. But I can show it to you guys here. So if somebody's falling, you know what? I'm blinded. That's okay. Okay, I can see you guys now. So if somebody's falling, again, it's the reflex reaction, right? It's so quick that you can't really, somehow in that slide said, or you may not even remember my name, somewhere I heard you want to put your leg this way, none of that's going to happen. It's very quick. So grab the person who's falling, hold them, but then guide them to a fall. Don't grab them and stop them from falling. That's not going to happen. They're going to fall on you and it's going to cause more issues. Okay, sorry. So guide them, let them fall. Look at my stance here. Can everybody see me? So I'm well supported here. Look at my stance. Don't stop the fall. You won't be supported. You're going to fall as well. So guide them, just protect their head. Okay, fall. Okay. So just protect their head. Okay, and make sure they're warm. That's the whole idea behind this slide. Just do not control their fall. Do not prevent them from falling. They are going to fall. Just make it a little bit smoother and protect their head. The other things you want to remember here is once they're fallen, please don't try to move them. You don't know the extent of their injury. They might have a cord injury or they might have had a vertebral fracture. The more you move them, you're making it worse for them. So wherever they are, let them be there comfortably. Try to make them comfortable. Don't move them. Okay? Again, a person who has just fallen might be disoriented. But sometimes, like my mom, you've fallen and you pick her up, I'm all right. And she'll just walk off the room like she's fine. But always make sure that you have a follow-up with them. Okay? And if someone's feeling dizzy as well but hasn't fallen, do the same thing but try to guide them and help them on a chair and let them settle down. I put a small point about seizures there. So if somebody's having a seizure, don't try to have very violent motions. Don't try to prevent them. Don't place anything in their mouth. Let them settle down. Okay? How to get up if you've fallen. So there are two scenarios here. You've fallen and you can get up, or you've fallen and you cannot get up. Let's talk about what you can do if you can get up. So, can everyone see me here? No?
You could maybe come to the aisle.
I'm going to try it here in the middle. Is that better? Okay. So if you've fallen again, try to turn onto your side, any side that you can at that point, okay? Try to scoot to a furniture that's close to you. Okay, if I use you here, okay? And hold on to the furniture and try to get on your foot this way. Push off and then stand up. Always at each stage, give yourself some time so your blood pressure settles down. Any questions there? Yeah. What if you cannot get up? Try not to panic. It's easier said than done, right? But try not to panic. There are several ways you can call for help. Always some patients always tell me, I have my cell phone with me all the time. You have those life alerts now. You also have some sensors. You don't have to do anything. It senses the change in the velocity of your motion, and it knows you've fallen, and help is on its way, hopefully. Okay? So, any questions so far? No? Either it was super boring, or you didn't get anything, or anyway. Like I said, a lot of times balance issues and falls can happen due to a small issue in your inner ear. And Ruchira here is going to talk to you a little bit more in detail about those inner ear issues, what they are, what causes them, how they affect your balance, and how to prevent them. It's more simple than you think. So this is Ruchira here, and I'll let her take over. Thank you, Sahana. Can everyone hear me? Yes. All right. It's an absolute pleasure to be with all of you here today, and I thank you all for coming. I just wanted to say that I'm really excited about this opportunity to be with you, and as you can see, I'm super nervous. So if I stutter, stammer, or even faint, come get me, okay? All right. So we are going to talk about this condition called as vertigo, or it's called BPPV. Before I go into the details of that, I wanted to share with you a story. So I did this course, which is to treat vertigo. I'm super excited about the course. I thought, wow, I'm going to rock the world. I come back to my clinic, and there's my first patient. So she's this lady who works at a school, and every time she looks up to change a light bulb, she feels like everything around her is just spinning. So she's like, you know what, I'm not going to look up. Like, that's the easiest way you can do. So she starts changing the light bulbs like that. And one fine day, she's asleep, she's laying in her bed, she gets up, and everything starts spinning. And that's when she comes, she's referred to our clinic. And I'm like, okay, and she asks me, hey, Richard, do you think this is fixable? And I'm like, oh my God, I just did the course, and I hope it is fixable, and I don't want it to act like I don't know anything, and I don't want to tell her that I'm going to make you feel terrible. So I'm like, of course, I'm going to fix you. So I worked with her for like 2 sessions. I did exactly follow the textbooks up to the T. I take her, do all the techniques. After 2 sessions, she gives me a call, and she's like, you know what, Risha, I'm not going to come back. I thought, oh my God, I messed this up, and I made her feel terrible. So I called her, I'm like, why are you not going to come back? She's like, you know what, I'm fixed. I can look up and I can change the light bulbs. And I'm like, oh my God, that day I think I had the best sleep ever. I felt like a superwoman, and I thought, oh my God, this is amazing. So the takeaway from this story is that it can happen to anyone, but don't panic, it's fixable, it's curable, and like this. If you diagnose where exactly the lesion is, you can treat it in like 1 or 2 sessions, okay? So it's that powerful, and that's why I hope you guys, please pay attention. If I see anybody yawning, all right. So what it feels like in BPPV, like it can happen like you get up in the morning and everything starts spinning. You almost feel like you're on a roller coaster and you want to just get out of it. You know, it's that crazy. So BPPV, it's a fancy term, but let me just split it out almost like a tongue twister. So B is benign. So it's not cancerous, it's pretty fixable, it's localized, and it's in your inner ear. So there is trouble in your inner ear. P means it's paroxysmal. That means it can happen all of a sudden. It can happen to anyone, it can happen all of a sudden. P, it's positional. So it happens with change of position. It can happen when I'm looking down, bending something up, I'm laying on the bed, trying to get up, so it can happen anytime. Now what I want to make a point here, it's different from when you have blood pressure issues. So if you have a blood pressure problem and you try to get up, you may feel a little lightheaded, you may feel like a little bit of a blackout, but it's way different than this. In this, you'll actually feel like everything is moving. So it's pretty debilitating that way. And V is vertigo. Vertigo actually means like a spinning sensation. Any questions, anybody?
Yeah, there's some things that are a little different than spinning that's also in your ear.
So that's what Ricky is going to talk about. Okay. So that's when your eye and the brain coordination is not working, and it may be a little bit off balance. Kind of that way. All right. So let's go into the statistics of it. Before I go into this, around 45% of people fall because of DTD. So it's a pretty huge number, but it's one of the best treatable conditions. It's overlooked, it's debilitating, causes loss of balance. It's very common in the age group of 60 to 70. And women are more likely affected than males. I think we women suffer quite a bit more than men. Don't you agree? All right. 9% of cases go undiagnosed in young adults. So that lady who came to me, she was suffering for this for 15 years and she didn't pay attention. So it was like a really powerful thing for her. So make sure you're aware of the symptoms. 36% of the people are afraid of falling. Like obviously if something moves you, you're going to get scared. 33% people have nausea and 49% of people feel off balance. It's a pretty common cause. It can occur spontaneously in most cases, but it's also seen to occur after an ear infection or a head trauma. So be aware of that. If you had a ear infection and afterwards you start noticing any of these symptoms, please pay attention to that aspect as well. All right. I'm not going to go too much into detail of this, but before I go into further slides, I want you guys to explain the anatomy of the inner ear. It's a little complicated, but I'll try to make it as simple as possible. But if you have any questions, just feel free to let me know, okay? So there are 3 pipes. Okay, there are actually 3 little pipes in your right ear, and there are 3 little pipes in your left ear. Everyone on board with me on that? All right, perfect. And then we also have a little box, okay? It's called otolith organ. You don't have to remember the fancy name. So there's a box here, there's a box here. Okay, there are 3 pipes, box and box, okay? Inside the box are tiny little calcium crystals. Did you guys know you guys have crystals hidden in your ear? So it's pretty nice. And inside those crystals are surrounded with hair-like cells. It's almost like hair. Okay? So better than mine, hopefully. So what happens is every time I turn my head to the left, okay? If I quickly move my head to the left, there's going to be a movement in that box. So that's going to let my brain know, hey, Ruchira has turned her head to the left. If I move my head up and down, again there's going to be a movement in that box and that crystals that's going to let me know how my head is oriented in space. Now, if these crystals decide to misbehave one day, they're like, we no longer want to stay in that box and we want to go and jump in those pipes. So it can happen anytime. I'm bending over, coming up, those crystals can go into the pipes. And if that happens, now your brain is confused. It doesn't know where your head is because it's not functioning properly. So all of a sudden, instead of you seeing the image stable, now since the brain is confused, it cannot send signals to your eyes. So your eyes don't know where things are. So there's a huge confusion and then everything starts to move. Any questions with this thing here? Okay, perfect. So now of these 3 pipes, there are 2 pipes which are vertical and there's 1 pipe that's horizontal. So it's very important as physical therapists for us to diagnose whether those crystals are in the vertical pipe or they're in the horizontal pipe. And sometimes they can be in another part which is called as cupula, but this is a very rare form of vertigo. But this one, which is canaloliasthesis, which is mainly the pipe, that's a very common form of vertigo. Okay? Any questions with this at all? Yes.
The crystals that are in the box, they're there intentionally? I mean, God put them there?
Yeah, God has put them there so that we can see.
Not a result of disease?
No, not at all. They are there. They are there in me, they are there in every person.
I had it backwards.
Yeah, no, not
I
at all.
thought the crystals that formed
No.
were
And that happens
interfering with the
sometimes in our
sleep.
bones. So like if there's a tendonitis, you may get a bone spur or something like that. But these crystals are there in everybody. But they're there in that box. They are not supposed to be in those pipes.
And they cause problems when they pop out of the
Box and go in those pipes, yes. And if they stay in the pipe, and especially when you're laying down, they go more in the pipe, and that's what causes that dizziness. That's a great. Yeah, sure.
Maybe it's just me, but is it hot in here?
It is.
Did we do anything about that?
Yeah, sure. I'm sweating too, but I thought it's because I'm speaking.
He's at it.
All right, so the common complaints that people have are because of positional change. So they'll say complain of a spinning sensation, which is pretty common, which can happen if they're rolling in bed. It can happen when they're rinsing their hair in the shower, when they're bending over to do gardening or any sort of that activity. And mostly it happens with movements which include your neck extension and rotation kind of movements. And the patient may have nausea and vomiting associated with it. And a lot of times when we do the tests on people, we would also see their eyes jiggling a little bit. And that is what we call as nystagmus. Okay? All right, you ready for some fancy tests that I'm going to show here?
No.
All right. So Ricky is going to be our model here. All right. Come up here. Can you everybody see? Okay. So say for example, Ricky, which direction when you turn do you get dizzy?
To the right.
Turn to the right. Perfect. So every time you look to the right and up, you feel like everything is spinning, right?
And then the environment spinning.
Oh God, let me help fix you now. So, all right. So what I want you to do, you're going to stay in a long sitting position. And I do not recommend anybody trying anything of this at home. It's always a good idea to talk to your physical therapist, okay? Because a lot of time people will go on the internet and they'll be like, okay, let me just try this out. But it's very important to know how to do it. Okay, so what I'm going to do, I'm going to make Ricky turn 45 degrees to his right. I'm going to support his neck, and it's going to be a quick movement, okay? So I'm going to just pull him quickly down.
Oh my God!
So this is a positive test. The minute you take him, you're not serious, right? Okay. Okay, so I'm going to take him into this position, and if he feels that spinning sensation, that's a positive test. So this test is called Dix-Hallpike's test, okay? So what I'm going to do, I'm going to let him come back up. I'm also going to check his other side just to be sure. So then I want him to turn to the left. I'm going to do the same thing. How do you feel? It's fine, perfect. So he's the perfect model. Okay? Everything is not ideal when you see the patients. Okay, so what I'm going to do, it's called a correction maneuver. So this tells me that his crystals are in those vertical pipes. Okay, so I'm going to correct that, and doing this couple times and even in couple sessions, the crystals get back into the box, and normally the results are pretty miraculous. Okay, so what I'm going to do, I'm going to take him back to that test position. So turn to the right. I'm going to come back. He's such a great actor. Okay, so we're going to stay in this position. Okay, Ricky, I know how it feels. So stay here. I want you to keep your eyes open. So the reason I'm telling him to keep his eyes open is I want to see that jiggling that I talked about. So based on how his eyes jiggle, it gives me an idea of what's going on. Now if the crystals are in the pipe, his dizziness should subside within about 30 seconds or so. Okay? If it doesn't, it's in that rare form that I talked to you about. It could be that kind of vertigo. Okay? Are you okay? Doing all right?
Yeah, it's better.
Okay. So then what I'm going to do, I'm going to turn his head to the opposite side. And again, I'm going to have him stay here in this position till his dizziness subsides. Or if it doesn't, at least 20 to 30 seconds. Okay, after he's done in this position, he's going to roll over on this side. Okay, and again, we're going to stay in this position till his dizziness subsides. I'm going to support him all through. And then, there's not much room here, but then he's going to get up. And he's going to still keep looking down. Okay, so this is the corrective maneuver that we do to get those crystals, if they're in the vertical or not. All right. Now say the crystals are not in that vertical pipe, but they're in that horizontal pipe. So how do we test that? All right, you're back. Yeah. Right, so what I'm going to do, I'm going to bend his neck to about 20 degrees, and then I'm going to have him turn to one side. Are you feeling dizzy when I turn you to the left? Okay. And how about the right?
It's more severe.
More severe on the right. Okay, so let's come back up. Okay, so what I'm going to do this time, I'm going to have him sit this way. So Ricky, just hang in here. So his symptoms are to his right. So what I'm going to do, I'm going to have him go to his left. So he's going to quickly, so I'm going to quickly lower him to his left. And I don't know if everybody can see in here. So again, I'm going to stay in this position till his dizziness subsides. Sometimes it can be up to a minute or so. And then after that, I'm going to quickly rotate his head down towards the ground. Okay. And again, I'm going to stay in this position till his dizziness subsides. And then he's going to slowly come back up, still looking down. Okay. So this test is what we call Appiani's test. So it's very crucial for us to know where the crystals are, whether they're in the pipes, they're in that different part called cupula, whether they're in the vertical canal or they're in the horizontal canal. So based off of that, the treatment is pretty simple, but it's very important for us to diagnose and see how things are going. Okay, so I would recommend you guys, if you feel dizzy, don't Google, don't go on the internet and try this on your own. Come to us. All right? Awesome. Any questions? Anybody? Go for it.
So does BPPV
Mm-hmm.
have any connection to if you have loss of hearing or hearing?
Not really, no. Not really. So this has nothing got to do
So
with it.
does, if you have a loss of hearing or wear hearing aids, does that have
No.
anything to do with?
I wish it could cure that, but
Nothing
no,
with-
nothing,
nothing to do
no,
with
no.
that.
So your inner ear is a separate balancing apparatus, so it's nothing got to do with your hearing at all. But that's a great question. Like that. Any other questions?
Intense can
It
this?
can be severely intense,
Because
like,
I've heard cases where
yeah, you,
they have this dreadful dizziness and then
you can
they're
do,
out for the whole day.
yes, yes.
So can the same treatment be
It
done
can
here?
help. A lot of times it's recommended you see your physician. If it's too intense, they give like a vestibular suppressant to you. But then even after that, you may not be completely healed. So you've got to do this test to do these maneuvers to get the crystals set back.
So
But it can
could,
be
happen anytime. I mean,
anytime, yeah.
it could recover.
But it recovers, yeah, absolutely, absolutely. That's good. Thank you.
So after this,
Uh-huh.
I think you see this normal
Uh-huh.
crystal
In place. He doesn't have to do it at all after
No
that.
follow-up,
No, no,
no
no.
medication.
No, nothing. He doesn't have to keep doing it if he's not busy anymore.
But you want to take it easy for that day.
Yeah.
You don't want to go to a Zumba
Take
class
it easy.
afterwards.
Right.
Or make sure there's someone drive you.
Yeah, that's another one. And also when you're sleeping, it's important you keep your head propped up because that extension and rotation position causes that dizziness to come back. And also it's recommended, say he had dizziness on his right side, so he shouldn't sleep too much on the right. It's better that he sleeps in that corrected position on the left. Yes.
How do you know that the crystal is in vertigo pipes or in
Horizontal. So that's the test I did here with him. So the first test that I did, that was for the vertical pipe. But the second test that I did, where I bent his neck and rotated side to side, that was for the horizontal pipe. So based off of which test he comes positive, and sometimes he can come positive both tests, but one test would be more positive than the other. So then you fix that first and then you address the later. And if for any reason person cannot tolerate this, because sometimes you cannot take them into this position. So there are other exercises too, which we call habituation exercises. So those are relatively milder. They take long time for the crystals to go back to the pipe, but a lot of time people have neck fusion or they're not able to tolerate quickly dropping them down. So then there are other alternatives for that as well. So, any other questions? That's great. Thank you so much. I had a great time. Now we'll have Ricky take over and he's going to talk about
gait stabilization exercises. Sometimes even after BPPV, you may feel normal, but then you're walking and taking a sudden turn, and you may feel off balance. So something like what you have been talking, right? Was that your question? Yeah, so sometimes when you're walking and take a sudden turn, you may feel off balance, you may not feel everything spinning. So Ricky's going to take over and he's going to go through some of that stuff. Thank you so much.
Right, so I'm so excited to talk about this topic. I'm also excited to come back here. The reason I'm so excited is because in my opinion, this is the most amazing structure in human body. Imagine there is the structure, three-dimensional structure diagonal to each other in the inner ear. It's crazy, it's just unreal. Okay, so the first concept I'm going to talk about is called vestibular ocular reflex. So in short, VOR. It is really important function of inner ear. So in short, let me describe this reflex. So the function of VOR is when you stare at something. For example, if I stare at a cheetah, and if I turn my head, I can still focus on the cheetah. So if think about it, when your head is turning to the right, your eyeball has to turn to the left to fix on the target, right? So that's VOR. So you turn to the left, turn to the right, then the eyeball turns to the opposite direction. So it is survivally extremely important because, think about it, if you are, say, chasing a dog, and you have to focus on the dog, and you are running because your head is moving constantly and shaking left to right, and you have to focus on the dog so that you don't trip or bump into a tree. Or you are being chased by a dog, and you still have to focus on the front, and your head is still turning, and you probably need to turn to the left or turn to the right. The VOR function makes sure you don't bump into a tree. Okay? So this is the anatomical structure. So there's a inner ear vestibular organ in left and right. So they align perfectly diagonal. So it's really cool. And that's the structure Ruchira just talked about. This is basically the box she was talking about, the crystals here. And this is the three pipes. They are aligned diagonal to each other so that you can detect the rotation in this direction, and this direction. Okay? Even you can't see anything, even in the dark, even you can't feel anything. So what makes this dizzy? So this is an analogy invented by me. So imagine you're turning your head and there's an iceberg in. Imagine your brain is the captain of the crew, and your inner ear is the sailor. Okay? So there's an iceberg in 1 o'clock direction. Ideally, the right side inner ear should tell you the target is in the 1 o'clock direction. The left side will tell you in the 1 o'clock direction. So that's a perfect situation. When the inner ear function is not functioning well, the right side sailor may say the iceberg is in the 2 o'clock direction. And the left side inner ear is telling the iceberg is in the 12 o'clock direction. Then the captain, which is your brain, is really dizzy. He's confused about what's going on. Okay. So that's what's happening when your vestibular function is not ideal. And that's the reason why you feel dizzy. Because there's a conflicting signal sending from both sides to your brain, and the brain can't process it correctly. All right, so how can we fix that? So the exercise is called Destabilization. If you look at the exercise, basically you're shaking your head. But it's important because it's just like a weight training for your brain. So if you lift weights, you're lifting a really heavy weight so that your muscle can adapt to the weight and getting bigger and stronger. For the gait stabilization, it's just like a weight training for your brain. So you are constantly shaking your head and give wrong signal to the brain and let the brain to adapt to the signal. So the captain eventually knows the right side sailor is going to mess up direction, and the left side sailor is going to mess up direction too. But you eventually know how they're going to mess up, so that you know where the iceberg is, so that your ship doesn't bump into the iceberg. So I am gonna demonstrate the vestibular, the gait stabilization exercise. So what you need is a business card. I have a Prenas business card. Okay. So first, keep the business card about arm distance away from it. Don't worry about 6 to 10 feet, that's too far. So what you're gonna do is, so in a safe environment, make sure you don't fall because it's gonna cause some dizziness. You stare at the word or text on the business card, so I say Prina, and turn your head side to side, 30 degree left, 30 degree right, and shake your head. All right, the following part is the most important thing. So turn your head as fast as you can, but not too fast to make you dizzy. Okay? Turn your head as fast as you can, but not too fast to make you dizzy. You want to see the text, and you don't want to see the words jumping. You want to see the words really crisp. Okay? So that's the speed you want to shake your head at. So what I'm going to do is shake, shake, shake. So I can still see the word Prina clearly, but if I turn this way, the word Prina is jumping all over. So I want to stay at this speed. That's the perfect speed I want to have. So I do this for about 30 seconds to 1 minute. So that's just like you're lifting the right amount of weight for your muscle. Okay? So left and right, 30 seconds. Make sure you're in a safe environment, you don't fall. Take a break. Then vertical, up and down. So again, you're nodding your head, 30 degrees on top, 30 degrees below. So you're still focusing on the text. Shake your head as fast as you can, but not too fast that you start to feel dizzy. Okay, again. So 30 seconds or a minute. So horizontal is important for the situation when you walk in the street and turn to the left or right because you're turning horizontally. Vertical is important when you lay down or come up. So both are extremely important. You wanna strengthen both directions. Okay. If you have a certain balance issue, I recommend you can stick on the wall and have someone guard you to prevent you fall when you do the stabilization exercise. So again, as fast as you can, but not too fast to make you feel dizzy. Okay. So that's the basic. Just like weight training, we have some progression. So this is called ×1. So the target is fixed in the position, all right? So if you want to make it harder, I don't recommend people start with ×2. The ×2 is like, when you turn the head to the right, the target goes to the left. It's much harder. So you can see I'm slower in shaking my head. Because if I turn a little faster, the text screen is just going to jump over. So up and down. So you will be surprised. This is the basic exercise. Actually, going to affect your life if you have a dizziness, big time. And for a lot of dizzy patients, for example, the BBPV patient, after they fit a crystal, they might still have a minor symptom, or when in daily life their function is not quite there yet. Function meaning like they can do everything they want. So in that case, what you're going to do is basically work on the BOR exercise, or we call it gait stabilization. So we can do horizontal, vertical, ×1, ×2, and we can cooperate with all the balance exercise we are going to show afterward. Okay. So I think there's a question there about the symptom. Does anyone have any question? Okay, go ahead.
How about the third dimension?
Third dimension. It's a good question because the vertical canal is aligned like this. So when you do up and down, you are actually affecting both this dimension and this dimension. So horizontal is horizontal, so it's like this. So when you turn your head, it's like here. But the vertical is like this. So when you do this, you're affecting 45 degree here and 45 degree here. So you're affecting both vertical canal. That's why you don't worry about it. Okay. Any other question?
I do.
Yep.
I notice getting dizzy if I'm on the computer for a few hours and I'm building a database and I'm not even looking anywhere except at my monitor.
Okay, so anything vestibular affected is there's a positional change, okay? Well, for this case, for BPBV especially. BPB is the most common reason causes the dizziness, okay? So anything, the name indicates positional. So there's the positional change in your head which is directly causing you the dizziness, that's BPBV. If you look at the stationary target and your head is stationary, that might be something else. Okay. It could be the fluorescence of the screen.
Yeah.
So there are a lot of reasons. Actually, dizziness is a really huge umbrella term which includes a lot of reasons. We are talking about something related to inner ear. There could be a lot of like a central nervous system, your brain issue. There could be circulation issues. There could be any other reasons.
Yeah.
So, okay, go ahead.
The exercise that you were suggesting to strengthen the brain, will that help people who are very sensitive to motion sickness?
Yes, exactly. So that's actually a lot of time that's caused by the impairment of your both side theta is giving you the wrong signal to the brain. So motion sickness is one of the symptoms. Okay, the symptom of vestibular hypofunction, meaning that you have malfunction in your inner ear, is headache, dizziness, nausea. Okay, so what you just mentioned is one of the symptoms, and there are two fixed. One is gait stabilization, shake your head. And the other thing is called habituation. You just expose yourself in the situation, the condition that causes your symptom, and make sure to force yourself, to force your brain to adapt to it, but make sure that's in a controlled, safe environment. Does that make sense? It's just like you are lifting weights. You are giving like external stimulation to the muscle to adapt to that, but it's controlled. You don't want to like. After you're lifting 10 pounds, you're lifting 100 pounds, you can enjoy yourself. You are slowly progressing yourself. You are shaking your head slowly, a little gradually faster, and you are increasing the difficulty by times 2 or something like that. Does that make sense?
Yeah.
Did I answer your question?
So it doesn't mean that, for instance, I have problem breathing when I travel in a car, which I don't have while flying or in a train. It's only,
That's exactly because when you are in the car, your head is slightly moving, right, in space.
So do I make a practice of
yes,
forcing myself to breathe in a car so I get over it? Or?
Well, you probably want to start from here. I mean, that's really the basic. Right? The habituation is something in the later stage that you're going to do.
And maybe a silly question. We were talking about being in a safe environment for everyone, and also about sticking this up somewhere. So can you stick it up somewhere and sit on a chair and do this?
Yeah, of course. You can start from sitting.
Somewhat.
Or sitting. Turn your head from side to side. And then when you're really comfortable about that, then you move to you shift to standing position because that's more challenging. But what you can get is standing in the corner. So when you fall, you can hold on to it. Okay, does that make sense? Any other questions? Go ahead.
She wants a little bit more clarity on that. You're talking why you're doing these exercises that you're talking about. And I'm gathering that you're trying to just if you get some imbalances, you should do these exercises where you're saying. Am I correct?
Yes, so basically, your inner ear is sending the wrong signal. You are forcing your brain to adapt to the wrong signal so that you know what's going on. And eventually you can understand the signal sending by both sides of inner ear, and eventually you know the positional change of your head so that you can focus on the target you're looking at. Does that make sense?
Do you get that?
Go ahead.
Actually, also what I was going to ask is, if someone up front asks a question, if you could repeat it, because we don't know what it is you're addressing.
It's not loud enough.
It's not loud enough.
Oh, sorry. I think we'll have video, right? So it might help you. Well, so what's your question? I can quickly give you a quick answer.
No, it's this, the lady up front
Okay.
obviously had an involved question.
Okay.
You're giving her suggestions,
Oh.
but we have no idea what it is.
Okay.
What they're
Okay.
saying.
What you're talking
So,
about.
what was your question again? Sorry.
There are a couple of aspects to that. One was I said,
Oh, yeah,
does
yeah, yeah.
this exercise have to be done standing up, or could we just sit on a chair and, fix that?
So
that
the
is
question
fine.
is, if you can sit, because standing is pretty challenging. You may shake hand and fall. If you can sit and do a shaking hand exercise, the answer is yes, because it's safer. But again, you're lifting lighter weights, so it's not challenging yourself enough. You want to make sure you're safe. In a safe environment, challenge yourself as much as you can. Okay? I think the other question is in the bus, right? So when she's in commute, she feels dizzy. So that's exactly the case. So because if you're sitting in the bus or if you're in a commute, there's a minor shake or like positional change in your head. And if you read something in a commute, you have to stay focused on the text, right? That's exactly the case. So if you have that issue, go ahead and do the shake head exercise.
Thank you.
Okay. Go ahead.
How often should those exercises be done, and under what circumstances would I actually start doing it? When I feel dizziness or motion sickness, or just for fun?
So first, if you have motion sickness, come to physical therapy and consult the physical therapist, because you want to know your baseline is. It might be too much for you to start just directly shake your head. The physical therapist will decide if you're going to start from sitting or directly from ×2, or you have a problem with vertigo or horizontal. So first talk to physical therapist. Second, the exercise is usually done every day, over twice a day. Especially when you start to, your symptoms start to subside, you want to progress a little more. Okay, so what's the other question? Okay, cool.
Thank you.
All right, any other question?
Yeah, one more. So I've met people who will refuse to read a map in the car because they say it makes them car sick. Is this the exercise that would cure that?
Exactly,
Yeah.
exactly. So think about, as I was talking about, there's a positional change. Positional change can be as minor as a little bit shake, a little bit vibration when you're sitting in the bus or driving.
Is this condition something you're born with?
It's just like if you don't exercise your muscle, it's getting like the muscle gets weaker and smaller. It's the same condition. It's just like a function. You need to use it and get stronger.
Not a disease?
It's not a disease. It's more like an incline in your function.
Oh.
Okay. So just like your speed,
and that's getting up from the bed. Okay. How many of you get up like that from the bed?
Yes.
Yeah? A lot of us do, right? And you probably have seen all the therapists tell this to you guys 100 times. Every single time you get up from the bed here, we make sure that you're reminded. Every time you want to get up, turn to the side. It doesn't have to be the right, it can be any side you're comfortable, but please turn to your side first. Bring your legs down, then push off. Wait for a second, don't be too quick. Wait for your blood pressure to normalize, then come on down. You don't want to see anyone get up like that. I've had patients fall, I've had patients really dizzy, I had to hold on to them, so I don't expect any of you to practice this. This is just for you guys to remember. Second thing we're going to work on here is, there are a bunch of exercises, but we'll be working just on a few. Sit to stand. So PTs and our aides are going to help you guys. We're going to work on how to stand up safely from a sitting position. So how do we do this? We're just gonna group. Just gonna practice some sit to stands.
We have them on.
Okay.
I think they're all in place. Do you want wheelchairs or do you want?
Yeah, we could just group some chairs so everybody can practice where they are.
So do you want to demo first?
Do you want to demo? Yeah. Okay. Again, standing up from a chair. A lot of chairs may have support. Some of them don't have supports. Sorry, I'm just looking for
a chair with support.
No, I'm just looking for a walker. May I borrow this for a second? Okay. And again, how many of you get up like that? I know one person who does. He's not here. He's hiding somewhere. Okay. Do not stand up holding on to your assistive device. Okay? This is unstable. You might fall if you're standing up holding on to this. So always scoot to the edge of the chair. Hold on to the surface that you're sitting on. Just the chair or sofa, wherever you're sitting. Use your legs to push off, then hold on to your assistive device. Do not attempt to get up like so. Does that make sense?
Yep.
Does anyone want to practice this?
How about a chair with
Because we brought out the chairs.
Chairs with wheels. Chair with casters.
What's that?
Chairs that have wheels.
Uh-huh.
Not wheelchairs, but
Try to
chairs
avoid
that-
sitting on chairs with wheels.
Yeah, they're gonna roll away. But office chairs have wheels on them.
Do they have hand rests? You can hold on to the rails.
Some do, some don't. Right. Some on the edge, the whole thing may tip over.
Oh, this is an example.
Right. That's a standard
Any-
office chair.
Any suggestions, PTs, how to get up from a chair which has wheels?
You could potentially roll the back of the chair all the way up to a walled surface so that it's not going to be rolling away from you.
It's one possibility. Another possibility is if you have a table, if you're working here, I would hold on to the table, which is a more stable surface to
If I
stand.
fall, the table will fall on top of me.
What's that?
The table might fall on.
Well,
Very
Come to PT and we can help you figure out some of these
let's get a
problems
new
to solve.
chair for your office.
Yeah, different chair.
You need to get a different chair.
I just have a question. There's
Yes.
some of the wheelchairs.
Yes.
People with, there are brakes on the
Yes.
wheelchair.
Yes.
Do they have to be set by somebody else, or can the person on the wheelchair put on the brakes themselves?
They can pretty much put the brakes by
In which
themselves.
case, I would think that you'd have the brakes on before you stand up.
Absolutely, yes. That's a good point. If you have one of these rolling walkers, when you stop using them and you're sitting down, please make sure you lock them. Again, you don't want to hold on to them when they're unlocked and you might start to move. Yeah, that's a good point. Okay, so if anybody wants to practice sit to stand,
I'll do that.
yeah, our aides are here. We can help you see if you're doing it the right way. Yeah?
I think we'll get big group participation.
Yeah, there are several chairs here. We're going to bring these tables down here to
Just do it. I can hold it.
Well, you don't have to
Here,
use them.
I'll hold it for you.
Okay.
Questions?
Aides and PTs, make sure they're always
No, I don't think so. I speak English because we were in Thailand, but I speak Tamil.
If you want to try it out, how to stand up.
Definitely make sure that your legs a little bit in front, far forward as you can. And then as I hinge forward, my bottom comes up. I'm pushing off of this. So because that's going to be the number one thing. You know, if you should practice getting up and down out of chairs. All right, we're going to go back to this one. practice it again. Because it's hard to want to picture. So we're all going to smile and look amazing and do this exercise together. Yay! I'm not allowed to do this one. You haven't graduated yet.
Throw you off on the floor. So start the presentation, safety first. Safety first before where they can hold on to.
And then gauge them on you.
How's your balance?
You're not there yet. No, you haven't graduated.